Everyone. Today we want to talk about hospital response to mass casualty events and disasters. First, I would like to thank each of you for participating in this exercise, as I know that it takes time away from your personal schedules. So what is an MCI event? An MCI event is any event that causes a disruption in the community's infrastructure. Usually it causes widespread human, material, economic, or environmental impact or loss. Oftentimes these events are sudden and we have very little time to prepare for them. The needs of the event will be beyond the scope of what you have with current available resources. So the types of disasters we encounter, we have man-made disasters such as traffic accidents, acts of terrorism, infrastructure, and issues and things of that nature. Over the past several years, we have ran into several issues of terrorism, and it has become an increasing concern, especially after the events of 9/11. We have natural disasters. We can prepare more for natural disasters because in oftentimes we can see them coming. Natural disasters will include things such as flooding, windstorms like hurricanes and tornadoes, extreme heat or cold, drought, and mudslides. So some common issues that we encounter. Most often, hospital staff are not very experienced when it comes to mass casualty incidents. This is due to the fact that there are very few technical MCI events. What we do understand, though, is that on many occasions, hospitals will operate under a certain type of emergency or MCI status, and that's due to surge capacity because, as many of us know, our local emergency departments are currently flooded with patients and lack staffing. A lack of planning. Research has proven that many hospitals do not plan well for disasters, especially internal disasters. Internal disasters being that those events that take place inside the hospital, such as widespread uh, outages and events and fires that take place inside the facility. Lack of resources. Again, a lack of available resources at your disposal to use at any point in time. As we said a while ago, surge capacity. Surge capacity has to deal with the current patients that you are treating. And then when we have an influx of patients from outside, this increases the stress on our hospital or facility. So the first thing we want to look at when it comes to disaster responses, where did the command structure come from? So the incident command process was actually developed by wildland firefighters in California in response to the massive amount of wildland fires. They actually developed the incident command system. The system has been modified for emergency medical services and hospital response. One thing that we always want to look at is command. It is important that someone take charge as soon as possible. It is proven that the earlier we establish a command, the better our response will be to that situation. So the person who's in charge is typically going to be that of the one with the most authority in the hospital system, which will be, in our case, for this event, the nursing supervisor or the charge nurse, depending on who that is and who we have available for the event. Remember that command can be transferred at any point in time. To transfer a command, it is important that you provide a good description of what is currently going on, the events taking place, and what needs to be accomplished. These should be written down and given to the next person who's taking command. Also, your staff, your hospital staff, should know that there's been a change of command. Now, in the event of a disaster, like I said earlier, command should be taken early. So what should happen is your emergency medical services crew or dispatch center should notify you early on that there is a mass casualty event so you can start preparing and have additional staff to manage that situation. During the event, You will have limited radio communication because of the amount of traffic going on the radio. So therefore, you'll have to utilize runners. Runners are established individuals that you have designated to go back and forth between doctors, x-ray, surge tech, and things like that to relay information. Logistics. For the purpose of this exercise, logistics would be consistent of a person who is designated to obtain supplies that are needed for the event. For example, if we need bandages, triage tags, things of that nature, this person will be responsible for that area. If you are a respiratory surge tech or x-ray, you would also need to designate your own logistics person as well. The triage officer. Triage officer probably plays the most important part in the event. Typically, this is delegated to the most experienced provider who is present. Typically, this person needs to be very experienced with assessment and rapid recognition of critical injuries and illnesses. There are 2 steps in the triage process. The primary triage will take place at the front door as your patients come in. It is well known that during disasters, as shown by the World Health Organization, that many patients will actually show up at your front door, not via EMS or any other way. So that primary triage takes place at the front door and basically designates how critical the patient is. Secondary triage will take place inside the facility once that patient has been evaluated. Now, remember, a patient's status can change at any point in time during that process. They may come in as a green tag, which we'll discuss a little further here in a little while, but after secondary triage may be actually transferred into a red tag or a yellow tag even. So this process is very fluid, and it can change as the patient goes through the process. There's 4 categories that we triage patients into. Red is the most critical. Yellow is the immediate. They have things like broken bones and things like that need attention, but not anything that is critical in nature. Green tags are your walking wounded. Typically, these are the ones that you see that are transferred up the ladder to either a yellow or red tag. If they're walking, we'll talk about this a little later, they need to be given a designated place to go to receive the secondary triage. Black tags are those that are deceased. Unfortunately, that includes both adults and children. We cannot dedicate resources to someone who has injuries incompatible with life. And that means sometimes that we have to make that hard choice of calling them a black tag. So the goal of triage is to do the greatest good for the most people. This comes from any literature that you will see regarding triage. And it's the staple point. The goal of triage is to the goal was to, again, rapidly assess and rapidly treat those major issues. Triage was actually developed during the Napoleonic Wars. There was a surgeon by the name of Dominique Jean Larrey. He basically developed a rule to triage those casualties of war, and they were treated according to their injury. This was without regard to their rank, nationality, or even if they were a member of the opposing army. Currently, we use a more scientific approach to the triage process. There are several forms out there, such as the START triage system, the SMART triage system, and the SALT triage. For this event, we will mainly be using the START triage system. So START means simple triage and rapid treatment. This was developed in the 1980s by the Newport Beach Fire and Marine Service, along with Hoag Hospital in California. It provided a rapid approach to triage a large number of patients for treatment. It's easy to remember, and it should take less than 30 seconds to implement. Basically, it relies on 3 major functions. It relies on respiratory, perfusion, and mental status. So respirations, the first thing you want to look at is if there's no respirations. If there's no respirations, we want to readjust that airway. And then we want to see if they start breathing on their own. If they do start breathing on their own, we want to immediately classify them as a red tag. If they do not, then they are immediately classified as a black tag. If they are present, are they greater than 30? If they're greater than 30, then we're going to classify them as a red tag. If they're below 30, we want to go on and move on to the second portion, which is perfusion. Perfusion, we want to assess to see if their radial pulses are absent or present. If the radial pulses are absent, or in a pediatric patient, if the cap refill is greater than 2 seconds, they are classified as a red tag. If the radial pulses are present and the capillary refill is equal to or less than 2 seconds in the pediatric patient, we want to move on to assess the mental status. If they have an altered level of consciousness, or if they are unconscious, they are immediately classified as a red tag. If they can follow the simple commands, then they are a yellow tag. So let's talk about our green tags. Green tags are, like I said, are often the walking wounded. These are the ones who are often moved up the chain of the ladder to the red and yellow tags. And in many cases will come to your facility walking in, and you will need to provide that initial triage for them. Black tags, again, are those who have no pulse, or they're not breathing after you realign that airway. We should not attempt any resuscitative measures on these individuals due to the fact that these resources are better needed elsewhere. Remember that working in the ER, if you receive a patient from EMS, they will be classified in one of these categories. The way that we want to move these patients is red tags should go first because they are the most critical, followed by the yellow tags, and then the green tags, and lastly, the black tags. This is an example of a triage card. When you receive a patient from emergency medical services, they should have a triage tag associated with them. On that triage tag, you will have very minute amount of information regarding the patient, including probably their age, injury locations, vital signs. Also, they'll have one of the 4 tear-offs at the bottom attached to them. As you can see with the triage tag, there is a barcode associated with that tag that allows the scene transport officer to basically identify this patient and make sure that they know which receiving facility they are going to. As the hospital staff, again, your primary goal as patients come through the door is to sort them appropriately and designate them to the appropriate location they need to go to. As EMS brings patients to you, you will do the same process. Even though EMS has done their own assessment, you will still need to do an assessment of these patients as well. Remember that you may not have enough beds initially to provide beds for these patients. Therefore, you must adapt and overcome and decide which patients need care promptly versus those that can wait. I hope this lecture was helpful to you, and if you have any questions, please let me know. Thank you and have a great day.